Welcome everybody. I'm Melanie Dizon and I'm the Director of Education for the Davis Phinney Foundation. And I'm really excited that you're here today on this webinar with Dr. Daniel Weintraub and Dr. Sonia Mather on psychiatric and cognitive complications in Parkinson's. Thank you both for being here today and helping us out with this really important topic.
Good afternoon, everyone. As Melanie mentioned, my name is Dr. Sonia Mather. I'm a family physician and a person living with Parkinson's disease, having been diagnosed over 21 years ago. I also have the privilege of serving on the board of directors for the Davis Phinney Foundation, and I have the pleasure of being your moderator for today. As we all know, Parkinson's disease is a pervasive illness. It affects us on many levels. This is not just a motor disorder. There are many non-motor symptoms, anything from skin changes to pain, to sleep disorders, to changes in mood and cognition. The last two are complications that can really truly impact our quality of life. And these are the important topics that we're going to discuss today in this webinar. Joining me today to talk about the psychiatric and cognitive complications of Parkinson's disease is Dr. Daniel Weintraub. Thank you.
Hi.
Dr. Weintraub is an assistant professor of psychiatry at the University of Pennsylvania and fellow at the University of Pennsylvania Institute of Aging. He's current recipient of a 5-year Career Development Award from the National Institute of Mental Health titled Depression, Diagnosis and Treatment in Parkinson's Disease. In addition, he is currently coordinating investigator for a multi-site international industry-sponsored study of the frequency and correlates of impulse control disorders in Parkinson's disease. So we are very fortunate to have Dr. Weintraub share his expertise with us today. So welcome.
Thank you.
So Dr. Weintraub, many of us notice certain changes as we get older. Sometimes we see someone that looks familiar and yet we're not able to remember their name. Other times we may forget to pay a bill or misplace our keys or have difficulty finding our words. And since we all also have Parkinson's disease, we worry that these are sort of initial signs of something more insidious, that our overall memory or cognition may be affected by the complications of this disease. So can we start with maybe you giving us a brief definition of what cognitive dysfunction is, what it affects, and how common it actually is in Parkinson's?
Cognitive changes, whether you're talking really about Parkinson's disease or even outside of Parkinson's disease, can fall into two general buckets. One would be milder cognitive changes or mild cognitive impairment, and that is common in Parkinson's disease and can even be common early in the disease course. And some of the things you already mentioned are some of the things that patients report to us: word finding problems, subtle changes with attention, concentration, maybe some issues with problem solving, multitasking, things that used to come easily before. So those would be some of the common changes early on. Many of those changes do not progress over time. They remain stable. Unfortunately, some patients, as the disease progresses or as the person gets older, can develop more significant cognitive impairment. And that other bucket is what we call dementia. So that is when the cognitive impairment has become significant enough, severe enough, that it starts to interfere with day-to-day functioning. And that would be the next step or the stage. So our goal moving forward is, one, to identify patients as early as possible in the cognitive decline process, to offer education, support, treatment when appropriate, and particularly moving forward as we hopefully develop disease-modifying therapies. Those therapies should be helpful for cognitive impairment as well. So it's important also to identify patients for that reason.
So looking at the scenarios that I mentioned a couple minutes ago, are these normal occurrences? Like, how can you tell what may be heralding cognitive decline versus normal forgetfulness?
I think if the changes are stable, number one, then you would expect and hope that for the foreseeable future, they should not progress. It's when changes continue to progress or become more all-encompassing that we start to worry about a more significant and ongoing cognitive decline. Mm-hmm. Many patients who have word-finding problems, for instance, or attention problems, may come back years later and say that those changes are still present, but they haven't progressed or become more varied or all-encompassing than that. There are factors that may predict who is going to develop more significant cognitive decline over time, but it's not clear that you can look at the type of cognitive impairment you have early on and say that's predictive of who's going to progress over time.
Do we have numbers, Dr. Weintraub, on the sort of percentage of people that will go from, say, a mild cognitive impairment to something like Parkinson's disease dementia? Are there any stats available on that?
We know that if you start at the beginning of the disease, so de novo untreated Parkinson's disease, approximately 10 to 20% of those patients may have mild cognitive impairment, depending on how the study is conducted. As the illness progresses and patients have the disease for longer, if you go out to 15 to 20 years, for instance, then probably the majority of patients who are still living would be diagnosed with significant cognitive impairment or dementia at that point. However, the caveat to all of this is that we have to remember that even in the general population, so these are people that do not have Parkinson's disease, by the time you get to age 85 or 90, approximately half of people meet criteria for dementia, which is most commonly Alzheimer's disease. So we have to just understand that the main risk factor, or a main risk factor, even beyond having Parkinson's, is just getting older. And people with Parkinson's disease are not immune from the aging effects that affects everybody else in the population.
Right. That actually leads me to one question that was asked by a viewer who was wondering how to differentiate between Alzheimer's and Parkinson's disease dementia, because she has a husband who has a family history of Alzheimer's and was wondering if his cognitive dysfunction should occur. How could she tell the difference between the two?
There's a couple of different ways to answer that question. And one simple way is just to say that if somebody has a diagnosis of Parkinson's disease already, they are really never diagnosed with Alzheimer's disease clinically. So once you have an established Parkinson's disease diagnosis and you develop cognitive impairment in the context of Parkinson's disease, then you're diagnosed with Parkinson's disease mild cognitive impairment or Parkinson's disease dementia. We really don't diagnose Alzheimer's and Parkinson's together. On the other hand, if somebody has a pre-existing diagnosis of Alzheimer's disease and develops signs of Parkinsonism, then they're typically diagnosed with Alzheimer's disease and secondary Parkinsonism. So the two diagnoses are really kept separately from a clinical standpoint. Now we know that what happens in a person's brain is not identical to what we may use in terms of clinical criteria. So about a third of Parkinson's disease patients who have dementia while alive also meet criteria for Alzheimer's disease at the time of autopsy. So the two do coexist together in more significant cases of Parkinson's disease cognitive impairment. So that's one way to answer your question.
Right. So when it comes to the timeline, because you say that you sort of watch things over time, and if things progress, then they could be progressing towards dementia, otherwise they may remain stable. Is there any kind of gauge of how long that process may take?
I think all the people on the call that have Parkinson's or their loved ones probably have heard this before and know it to be true, is that there is so much what we call variability or heterogeneity within Parkinson's disease that it's hard to make any sweeping generalizations about the typical course for a Parkinson's patient, because there is no typical course. So we know that there are some Parkinson's patients who develop cognitive impairment and even significant cognitive impairment early in the disease course. So they have a more rapidly progressive course from a cognitive decline standpoint. And yet we all know patients, many, who have had the illness for 10, 15 years and have very little cognitive decline. So then the question becomes, can we predict those patients who are more likely to decline long-term or more quickly? There are thought to be certain factors that are associated with more rapid or long-term cognitive decline in Parkinson's. We think that males more likely than females are likely to experience significant cognitive decline over time. That people with lower formal education levels, so higher levels of education may be predictive, are more likely to experience decline. We think that people who have a what we call postural instability, gait disturbance subtype of Parkinson's, so more rigidity in the axial in the center of the body, so less classical tremor presentation, may be more likely to experience decline.
Right.
There are certain psychiatric symptoms or other non-motor symptoms such as REM, sleep behavior disorder, also known as RBD, that seems to predict cognitive decline. So there are certain features that may be associated with longer term or more rapid cognitive changes. There are certain biological features that we can cover if we want to that may also predict those cognitive changes over time.
Yeah, we had a few questions about that. You mentioned that as we age, we normally become, more susceptible to developing cognitive issues. But is there any relationship between the age at onset, at diagnosis, and the likelihood of more severe cognitive decline?
It is true that the age, using that word age generally, has the most significant impact. So more than disease duration, more than one of the questions we received was about disease severity. So let's say higher Hoehn-Yahr stage or worse UPDRS motor scores.
Right.
Those factors probably play less of a role than just the age effect. So the older you are or the older at disease onset, the more likely you are to have cognitive impairment and cognitive impairment decline more than how long you've had the illness. So if anything, people with younger age of onset seem to be protected because they don't get to an older age for a longer period of time. So age does seem to be a major determinant. That being said, when we have done autopsy studies and looked at the brains of people with Parkinson's disease, those with more widespread brain changes are more likely to have cognitive impairment. So as it spreads the disease from the part of the brain that we associate with the motor symptoms more widely to the outer parts of the brain that we associate more with cognition or thinking, that does seem to be there does seem to be an association in that regard.
And are there any sort of comorbid other medical diagnoses that make it more likely for someone with Parkinson's to have cognitive decline as well?
I think that's an important question. While we're still in search of very good cognitive enhancing treatments, whether asymptomatic therapies or disease modifying therapies, what else can a patient do for him or herself? And we do recognize that comorbid blood vessel or vascular disease is an important contributing factor, both within Parkinson's disease and outside of Parkinson's disease. So by those illnesses, we mean things such as diabetes, high blood pressure, high cholesterol or triglyceride levels, obesity. Those are all factors that patients hopefully have some control over. They need to have good primary care management in terms of managing those conditions, because the more unmanaged those conditions are, the higher your blood pressure, the higher your blood sugar, the more likely you are to be damaging the blood vessels in your brain that contribute to your memory and thinking. So we may not be able to do much about the Parkinson's disease process right at this moment in time, but there's probably a lot that can be done about these other factors.
Right. So optimizing your overall health allows you to, in some ways, protect yourself to a certain degree, or optimizing the condition anyway.
I agree.
Sorry, go ahead.
And I was going to say the complementary piece to that, besides just formal management of comorbid medical conditions, are more general recommendations that we make concerning cognitive exercise, physical exercise, that are also meant to enhance your overall health, including your cognitive health.
Could you maybe elaborate a little bit more on that, what you mean by cognitive exercise?
There are numerous studies now that suggest anyway that if you engage in intellectual activities, something that you find cognitively stimulating, it can really vary for people. It could be conversation is intellectually stimulating, reading is, doing games, puzzles, whether it's board games or through the computer, anything that somebody finds intellectually challenging or stimulating, there is some preliminary evidence that that may be helpful to cognition. Whether it's helpful in the long term, we don't really know. Whether it's actually protective in some way, we don't know. But it's such an easy thing to recommend, and it just makes sense to do it, that we really recommend that people do that.
And that's cognitive exercise. Is there any objective evidence that physical exercise helps? I know it'll help with the diabetes and high blood pressure and that sort of thing, but that it affect cognitive decline itself on its own as a variable.
There is some evidence that physical exercise, both within the Parkinson's and the non-Parkinson's population, may have at least short-term cognitive benefits. So not only does getting your heart rate up 4 to 5 times a week for a half hour or more is kind of the general recommendation. And of course, with a Parkinson's disease patient, we have to be mindful that not everybody can do all kinds of exercise, but it could be vigorous walking for those patients that can do it, or maybe some other form of exercise. But there is some evidence that if somebody is able to get their heart rate up 4 to 5 times a week for a half hour or more, that may have at least short-term cognitive benefits as well.
So that's sort of things that we can do as patients in order to optimize our situation. But are there any effective treatments that you've seen that work really well in the context of a Parkinson's disease, say it's progressing to dementia, that sort of thing?
We are currently constrained to using the medications that were officially approved for Alzheimer's disease, so first tested and then approved for Alzheimer's, but they have been tested in Parkinson's disease cognitive changes as well, and we use them broadly. So there's 2 main classes of medications. One are called cholinesterase inhibitors, of which there are 3. It boosts the chemical in the brain called acetylcholine that's linked with memory and attention and other cognitive abilities. And one of those medications, ribostigmine, is actually FDA approved for the treatment of Parkinson's dementia. And then there's another category of medications that includes just one in its class, and that's called memantine. And that affects a different neurotransmitter in the brain called glutamate that's also associated with memory and thinking abilities. And there's some evidence that that compound may help for Parkinson's disease cognitive impairment as well. So at this time, those are the 2 really FDA approved available agents we have. But I do want to point out to people that there are numerous studies that are ongoing, both for mild cognitive impairment and dementia and Parkinson's disease, testing a range of medications, transcranial direct current stimulation, transcranial magnetic stimulation, deep brain stimulation. There's cognitive exercise studies ongoing. There's physical exercise studies ongoing, all for cognition. So I think there's an explosion of research in this area. So even though the options are somewhat limited now, I think there will be many more options available in the coming years. And we didn't get to, just in case I forget and that you want to get back to it, about other medications we may want to remove in terms of trying to be helpful for cognition.
Sure. I mean, you could go ahead and describe those.
So there's evidence now, both from outside of Parkinson's disease and within Parkinson's disease, that the class of compounds called anticholinergic medications, or those medications that block that same chemical I mentioned before, acetylcholine, are associated with worse cognitive performance and more cognitive decline long term. There are easy downloadable sheets from the internet that will highlight for you what are the medications that have anticholinergic properties that you may want to consider discontinuing or minimizing. And sometimes patients don't realize they're on one or more than one of these medications with these properties. The one that I use as an example, because it's the one people are most familiar with, is called diphenhydramine or Benadryl in the United States. So it's an anti-allergy and a sleep-enhancing medication that patients use, but it has very prominent anticholinergic properties. So people may recognize that they get a dry mouth when they take these medications, or they may develop constipation, but it can also lead to some cognitive dulling as well. So that's one class of medications to really take a close look at for yourself and with your physician. We also have to, unfortunately, sometimes use the class of medications called benzodiazepines or anti-anxiety agents for anxiety and sleep in Parkinson's disease. But we also recognize that those medications can have cognitive side effects. So those need to be used very cautiously. And then finally, certain pain medications, and I'm thinking specifically here of narcotics or opiates, can also have cognitive side effects. Parkinson's disease patients not uncommonly experience pain, but narcotics in particular have to be used very cautiously.
Well, that's great to know. I mean, I just want to reiterate what you already mentioned, that if you are on any of these medications, that you really do need to discuss it with your physician before stopping them, that should not be a decision you make on your own, because some you have to taper down and some are necessary. And sometimes you have to work with that side effect, I guess, or if you can't replace it.
Yeah,
But
very good point about sudden discontinuation of narcotics and benzodiazepines, because you can go through withdrawal syndrome.
right. But you, just to go back to the medications that you did mention, how effective are these medications?
Well, I'd say for the memantine, the second one that I mentioned, we have relatively little evidence. For the cholinesterase inhibitors, they seem to work as well or better than they work in Alzheimer's disease, but still the overall treatment effect is modest, I would say, on average. So there's definitely room for additional medications to be tested and hopefully approved for cognitive impairment, because I think the effects are not to the extent that we would want them to be. And I think it's also why we hold out hope that there will be more disease modifying therapies available, because to the extent that the cognitive impairment is associated with the progression of the illness in the brain, if there's disease modifying therapies that are able to slow or even halt that over time, then we'd have to think that it will also slow or halt the cognitive impairment over time.
Is there anything on the horizon that would improve cognitive impairment? So not just slow it down or stop it, but actually improve what deficits are already incurred that you know of?
Yes, not that I'm aware of. I would say that all of the disease modifying studies that are ongoing, everything that we hear about in terms of immunotherapies, antibodies or antibody therapies, all of them are incorporating or should be incorporating cognitive measures as well. So not only should they be looking at progression of motor symptoms, but I think the industry, the pharmaceutical companies have caught on to the fact that cognition is such an important issue in Parkinson's that they really should be assessing cognition as well. But in terms of pointing to a specific compound or class of compounds, I wouldn't say at this point.
Okay. To take a step back, if I or my care partner suspect that there may be some cognitive issues going on, what do we do next? Who do we go to? Who can help diagnose, and how will they do so?
That's a good question. And from my personal standpoint, being a geriatric psychiatrist who focuses really just on the psychiatric and cognitive aspects of the illness, I personally would like to see every patient who receives a diagnosis of Parkinson's disease get routine testing. It doesn't have to be detailed testing, but we have screening instruments such as the Montreal Cognitive Assessment or the MoCA that many patients are familiar with. And that really should be administered starting at the time of diagnosis and then annually. I think every year a patient should have a cognitive screening test done. And that doesn't happen currently, but I think it should. It only takes about 10 minutes to complete. So if you suspect that there's something going on, then that would still be the place to start, by probably letting your movement disorders neurologist or neurologist know about that, and that person can, or have somebody in their office administer a test. And these tests are relatively sensitive and somewhat specific about detecting cognitive changes. If that is not sufficient, then there are neuropsychologists that can do more detailed testing. Then you're talking about having maybe an hour to an hour and a half of testing that will really give you a baseline measure of multiple areas of functioning: memory, language, planning abilities, attention, and so on, that will really give you kind of an all-encompassing picture of cognitive abilities at this point in time.
That's great, actually, advice. I'm getting a lot of questions from care partners as well, because as you know, this disease affects whole family units, not just ourselves. So I guess, what advice do you have for care partners that are now facing a future with a loved one with cognitive impairment? For instance, there are certain complications that they end up dealing with. One patient or one viewer has asked about his father, who is now getting very vivid hallucinations that are taking up since his cognitive decline has occurred, for instance. So how should a care partner generally approach this kind of diagnosis in a loved one?
It's hard to generalize. You gave a very specific example there in a disorder that we haven't really covered yet in terms of hallucinations. So hallucinations and delusions together falling broadly under the umbrella of what we call psychosis.
Right,
And
we can talk about that.
occurs together with cognitive impairment.
Mm-hmm.
So as patients become more cognitively impaired, they're more likely to have these hallucinations. And hallucinations or delusions, which are fixed false beliefs. Hallucinations are a false sensory experience, whether it's visual or auditory. Those changes can then start to be accompanied by sleep disturbances or agitation. So this becomes kind of a small snowball effect. Cognitive changes, psychosis, poor sleep, can be agitation or aggression, and that can become quite an unbearable situation for family members sometimes. And often the patient may not have very good insight into these behaviors. I think some general things are to try to anticipate and not wait to get help until things become too far advanced, because then they hit a crisis point and it's harder to make decisions in a crisis situation. You're often left with going to an emergency room and scrambling to do something without the ability to be patient or think things through. So for example, some very basic advice is to consider whether a durable power of attorney is in place, whether advanced directives have been put together, which everybody should have, whether there's long-term insurance available, whether you've considered a day program to provide some relief during the hours, whether you've considered alternative living arrangements, whether it's for the patient or for the dyad, if it's a husband and wife. So these are things that sometimes people put off, understandably so, but then when you're faced with a crisis situation, it really makes it a much harder situation to respond to.
Yeah, you're right. I mean, it can be a huge task for a care partner to take on the care of their loved one when it gets to the stage of late dementia. And as you said, it's much easier to make those decisions together if done early enough. So you sort of prepare for the future. I think that's really important advice. You mentioned,
I'll mention one other point, just in respect for all and understanding for all that people have to go through. We hear so much about Alzheimer's disease, for instance, but having worked with Alzheimer's, but now really exclusively with Parkinson's, to me, Parkinson's disease is such a much more complicated and burdensome illness, because not only do you have at times the cognitive changes occur with Alzheimer's, but you have the whole neurological complication of Parkinson's, where patients may be less able to do things physically for themselves over time. So you can have both a psychiatric and a cognitive burden, but also a physical burden. And together, those two can make things very, very difficult, not only for the patient, but also for their loved ones.
Yeah, I have a tremendous amount of respect for care partners in general. I think they don't get enough credit for all that they do for us, for sure. Now, you mentioned psychosis, Dr. Weintraub, in the context of cognitive decline. Does it also occur in Parkinson's disease without a cognitive issue?
It can earlier in the course. We tend to call that minor or subtle psychosis. Benign is another word that's been used, but we do recognize that even early in the disease course, some patients can develop symptoms such as a sense of presence, so somebody being in the periphery of their visual field, or passage, feeling like there's something moving through the periphery of their visual field, or illusions, which is not an actual hallucination, but seeing something, there's something there, but misidentifying it. Those are all changes that can occur. And the reason now we think that they can occur even earlier on is that there are some changes in the brain that may be associated with the disease process itself that can cause some of these things, such as visual hallucinations. Now, that being said, a very strong predictor of who is going to have psychosis is how much medication you're taking. So the more Parkinson's medication you're taking, the more different medications, the higher the dosage, the more likely you are to experience these symptoms of hallucinations or even false beliefs. And that's the reason that one of the first things that the neurologist does is to revisit the Parkinson's medications after first ruling out that there's not an acute medical condition such as a urinary tract infection that could also be causing hallucinations, but taking a look at the Parkinson's medications before anything else is done to see if there's some adjustments can be made in that regard.
Do you think that's a reflection of the medications themselves or more a reflection of the severity of the disease that the medications are treating?
I think it's an interaction. So if you take somebody even who's a de novo or early Parkinson's disease patient and give them 1,000 milligrams of levodopa, carbidopa, levodopa versus 100 milligrams, they're more likely to experience psychosis at the higher dosage. But if you take somebody who's on 500 milligrams of levodopa and have had the illness for a year versus 10 years, the person who's had it for 10 years, who's also likely to be older, is more likely to develop psychosis. So there's probably both a disease or age and medication interaction.
Right. I think I'd like to switch gears if that's okay. We've talked a lot about cognitive decline, but the neuropsychiatric problems that can occur with Parkinson's are much beyond that. And one really common thing that I see in the community and even in myself are the mood disorders, particularly depression and anxiety. They're very common, as you know, in the Parkinson's population. The numbers that I've heard are that depression can affect up to 30 to 50% of individuals with Parkinson's, whereas that's only 10% in the general population. And anxiety has, I guess, similar numbers as well, where as only 5 to 10% of the general population experience anxiety. Would that be a fair number to throw out there?
I do think those numbers are accurate, and unfortunately they're also accurate for the other symptoms we talked about before, including psychosis and cognitive impairment. But yeah, I think between a third and a half of people at any given time or over the course of the illness can experience depressive symptoms and anxiety symptoms, and the two of them often go hand in hand.
Right.
So if you're depressed or have depressive symptoms, you're much more likely to have anxiety symptoms and vice versa than if you don't have either one.
So how can people tell if they're feeling down because they've been diagnosed now with an incurable progressive illness versus clinical depression? How can they tell?
I think it's not distinguishable, and I try not to spend too much time because I don't think we really are at a stage where we can do that. I think we understand that there's a biological component to the mood changes that can occur, and the strongest evidence for that is that Parkinson's disease, depression is an antecedent, or it can occur before Parkinson's disease in some patients. So in the years leading up to the development of Parkinson's disease, a person is more likely to be depressed than a person who doesn't ultimately develop Parkinson's. And that's probably related to the brain changes that are occurring in the mood centers of the brain even before the motor centers are affected. So that's really points to the biology of the changes and the neurochemicals that are responsible for mood regulation. But then we also know that when somebody receives a diagnosis of Parkinson's disease, it's a very major event in their lives from a psychological standpoint, from its impact on their functioning, their psychosocial situation, and then we understand that people can become depressed for those reasons as well. But we're not at a stage of our ability to examine the brain where we can say, oh, this is due to a biological change or to a psychological change, and the two kind of merge together anyway. So every biological change in terms of your mood is associated with a cognitive process, how you feel and think about yourself, and every feeling of hopelessness or helplessness or sadness is accompanied by a biological change. So the two are really joined at the hip.
Right. I mean, I think when you look at the diagnostic criteria for depression, it can be confusing because a lot of those symptoms are actually PD symptoms, if you think about it. The sleep disturbances, the fatigue, the changes in appetite, weight loss, apathy, and so forth. So it must be a very complicated sort of milieu to have to work through.
That's a very good point. So most of the symptoms that we use, there's 9 hallmark symptoms, and you just listed a bunch of them that we include towards making a formal diagnosis of depression or major depression, are symptoms that can occur just in Parkinson's disease without depression. And the easy way we've kind of dealt with that is to say, well, we should count them towards a diagnosis of depression by default, just to give the patient the best chance to experience improvement, which means offering them treatment, whether it's psychotherapy or antidepressant medication, because these are treatments that are safe and well tolerated overall. And we don't want to assume something is due to the illness when it may be due to depression.
Right. Now, are there effective medications that you could use to treat depression in the context of Parkinson's disease?
I think that there are. There's been multiple high-level studies, and the most high-level studies we have in medicine are randomized controlled trials where somebody's randomized to a treatment or placebo or fake treatment. And those kinds of trials have demonstrated effectiveness for a couple of the newer antidepressants, an SSRI, a serotonin reuptake inhibitor, a serotonin norepinephrine reuptake inhibitor. So these are very commonly available, commonly used medications, but showing effect in Parkinson's disease. One of the older antidepressants called a tricyclic antidepressant has been shown to be effective. And then finally, one of the Parkinson's medications, one of the dope class from a dopamine agonist has been shown in a clinical trial to be effective for depression in Parkinson's disease, not the motor symptoms. So we've had 3 or 4 studies now that have really highlighted that antidepressants can work for depression and Parkinson's disease.
Are there any medications that are normally given to patients to treat depression that we should stay away from? Any that will worsen the Parkinson's symptoms that you know of?
I think there's been concern, mild concern, I'd say, that some of the newer antidepressants, the SSRIs, can worsen tremor. But overall, the studies have shown that they don't worsen tremor to a significant degree and don't worsen the other symptoms of Parkinson's disease like stiffness, slowness, or gait imbalance. So I think overall, all of the antidepressants in and of themselves are safe and well tolerated in terms of Parkinson's disease use. The one caveat to that is the potential interaction between any antidepressant and being on an MAO-B inhibitor, monoamine oxidase B inhibitor, such as selegiline or rasagiline, because that will bring up a red flag from the pharmacy for the possibility of something called serotonin syndrome. So patients need to be aware of what serotonin syndrome is and should be notified about that potential from their physician before they embark on this combination of medications.
For those that may not be familiar, could you tell us what serotonin syndrome would look like?
So serotonin syndrome occurs when you're on 2 medications that can boost the level of serotonin in your brain and body. And if you're on a serotonin antidepressant, and then you're on an MAO-B inhibitor, which inhibits the metabolism of that medication or serotonin, then you're more likely to boost the level of serotonin even higher. Okay, so what happens if you have too much serotonin? You can get something called serotonin syndrome, which involves changes in mental status, where patients can become confused. They can become febrile, so develop an elevated temperature. They can get stiffness and rigidity. And really, it's a medical emergency or urgent situation where they have to get prompt care for that. So that sounds bad, and it is bad if it occurs. I do want to say that in the 19 years I've been doing this now, and I've seen many, many patients on the combination of an antidepressant and an MAO-B inhibitor, I've never had a single case that I'm aware of anyway where that occurred. So it's not that it doesn't occur, but that if it does, it appears to occur rarely, is my opinion.
Okay. And anxiety, something I think a lot of us struggle with, sometimes in the context of depression, sometimes not. How do you treat anxiety in Parkinson's? I guess probably like depression, you're not really able to discern whether it's normal worry from anxiety in a clinical sense, but how would you approach anxiety in a patient with Parkinson's disease?
So first, just in terms of the syndrome of anxiety, because it's a little more varied, I'd say, than depression, in that it can present in multiple ways. And I think that's important to highlight. There's generalized anxiety where patients tend to be just concerned or worried, and they would be overly concerned or worried compared with their usual self or compared with other people. So that's what we call generalized anxiety. There's people that can develop phobia symptoms where they're afraid to leave the house because of something may happen, or afraid to be left alone, or afraid to be in a social situation because of fearfulness over their Parkinson's symptoms. So those are generally fall under what we call phobia. And then there's another category that can occur that's really specific to fluctuations. So we know that patients with long-standing Parkinson's disease can develop what we call motor fluctuations, which means as their medication dose is wearing off, typically it's a dose of levodopa, not only can their motor symptoms worsen, but they can develop what we call non-motor fluctuations. And anxiety symptoms are a common non-motor fluctuation symptom when they occur. Sometimes people can become so anxious as their medication is wearing off that they develop anxiety or panic attacks. It feels like they're going to lose their mind or they're having a heart attack. Sometimes people end up in the emergency room as a result. And that's a sign of a non-motor fluctuation with a specific anxiety presentation. So depending on the exact type of anxiety and the context may guide the treatment. In terms of when we do use psychiatric medications, we try to use antidepressants first line because all of the newer antidepressants are approved not only for the treatment of depression, but also for anxiety disorders, generalized anxiety disorder, panic disorder. And since they're safe and well tolerated overall, we tend to use those first line. For those patients that don't respond sufficiently to an antidepressant, we do sometimes use anti-anxiety agents. They have to be used cautiously, as we talked before. But some of the ones that I use in clinical practice, not only clonazepam that we've talked about or haven't talked about, but is used primarily for REM behavior disorder or RBD at bedtime. We also use lorazepam, which is also known as Ativan for sometimes daytime anxiety. And there's also alprazolam or Xanax. So those are medications I sometimes do resort to for significant or disabling anxiety symptoms.
That would be very difficult if it was in the context of cognitive decline as well, because those are ones that you mentioned we can't really worsen the situation in that context.
We are sometimes caught between a rock and a hard place in treating some of these symptoms, and that would be an example right there.
So speaking of medications, I'd like to explore that topic a little bit more. The effect that our PD medications have on us, and what I'm talking about is impulse control disorders, which can really result in impact on all areas of life, financial, relationships, safety, and so forth. So for those that may not be familiar, could you please describe what an impulse control disorder is and how to recognize it and what we can do about that?
Yeah, these are sometimes really the most difficult situations I've had to deal with, and again, almost 20 years of doing this now, and sometimes the one that comes up the least because the information is sometimes withheld out of embarrassment or for any other reason. And it's also the disorder that I say is most strongly associated with medication use, because we know by studying untreated, newly diagnosed Parkinson's disease patients, they are not more likely to have these symptoms than somebody from the general population. It's only in the context of the treatment for Parkinson's disease that patients develop these problems. And they're more common than we once thought, and they're probably still common and somewhat hidden, I would say. So the medication class that's most strongly associated with it are the dopamine agonists. But we also know that higher dosages of other medications such as levodopa can contribute, and even other medications occasionally, such as MAOB inhibitors or amantadine. And the four main impulse control disorders are compulsive gambling, sexual behavior, buying, and eating. Beyond those four, there can be other presentations. So really it can take the form of any activity that a person is engaging in to excess, or in excess of what they would have done before. It could be a project in the home, it could be internet use, it can be any number of activities where the person can just not disengage from it. The four that I mentioned about before are the ones that were originally reported. They're sometimes the ones that might be the most harmful in some ways. And that's what we call impulse control disorders.
And what can we do about that? If, say, we notice that or often it's our care partner that may notice that our behavior is changing and is suspicious of this sort of ICD being there, what would you recommend people do? And how can it be treated, I guess?
So similar to what I mentioned for psychosis, but even more so in this case, is that the neurologist would typically want to take a look at the dopamine replacement therapy, the Parkinson's medications. And if this is a clinically significant problem, as it often is, if it's coming to the attention of the physician, then really some adjustment needs to be made to the Parkinson's medications. And we probably look at the medications in a hierarchy of discontinuation. So the dopamine agonist would be first, and then decreasing the dosage of the levodopa, eliminating an MAOB inhibitor, which is not an essential medication, looking at amantadine. So there's a series of steps that could be gone through. Sometimes patients really struggle getting off the dopamine agonist, and there's a syndrome called dopamine agonist withdrawal syndrome, where people sometimes just do not tolerate that well. There's a little bit of evidence that perhaps patients that are on longer acting dopamine agonists, so there's 24-hour versions versus multiple times a day, or on a patch formulation as opposed to an oral formulation, long-acting patch, that maybe those are less likely to be associated with impulse control disorders. Another way to consider the Parkinson's disease therapy in this regard is that sometimes patients may be referred for deep brain stimulation evaluation at this point, because they're on so much medication that's causing significant psychiatric side effects, and it's difficult to make adjustments to them, that perhaps the deep brain stimulation, if the person's a good candidate and if the surgery is successful, will allow the patient to be treated with far less Parkinson's medication after the surgery, which would then decrease the symptoms of impulse control disorders. We occasionally use psychiatric medications, and I'd be happy to mention those if you want.
Sure, go ahead.
Okay. So there's some preliminary evidence from non-Parkinson's disease populations for these similar disorders that antidepressants may have, particularly serotonin reuptake inhibitors, may help curb some of these behaviors, both gambling and sexual behaviors. One of the unfortunate side effects of antidepressants for some patients can be sexual dysfunction. So in this case, that might be a benefit if it's a sexual impulse control disorder. We actually conducted a study with a medication called naltrexone that's FDA approved for the treatment of alcoholism, that showed some suggestion of benefit for impulse control disorders in Parkinson's disease. And there's a few other studies that are ongoing, one testing an antipsychotic for specifically impulse control disorders. And there's another medication called zonisamide, which is an anticonvulsant medication that's being tested for impulse control disorders as well in Parkinson's disease. So there's a range of available options even from a medication standpoint, but the evidence is somewhat limited.
So there are things on the horizon, though, that are coming that could be helpful. You mentioned DBS, and there was a question, I think, that may resonate with other listeners as well. This viewer says that I had DBS surgery a year ago. Prior to surgery, I had no cognitive issues during my 14 years of treatment. Since surgery, I've been having serious cognitive problems. My question is, have you seen this? And is it possible that too much stimulation can contribute to the problem? So I guess the settings on their DBS they're wondering about. So is there cognitive issues with that can manifest after a DBS procedure?
The original studies of DBS, the kind of larger studies where patients, again, were randomized either to DBS or to best medical therapy, typically for a 6-month period, did demonstrate that those patients that got the DBS, compared with those patients that just received ongoing medication therapy, did have some decline in cognition on average. Now, the percentage of patients that experienced a significant decline was not high, but on average, patients did experience some decline. Now, those original studies were done in patients that were older, had longer disease duration. There's since been some studies in patients who are younger with earlier disease, and those studies have shown that from a cognitive standpoint, people seem to tolerate the procedure well, DBS. So it probably partly depends on disease duration and age. That's one factor to consider. There's also been some analysis showing that it may depend on the entry point through the front part of the brain. It may depend on the track that the wires go through in your brain, and ultimately, as this person was hinting at, it may end up in the location of the subthalamic nucleus, or the STN, where the electrodes are placed. Now, there may be adjustments that can be made in that regard. So that's good that the person works with a neurologist, but it's not easy to do, make quick changes, I would say. But there can be alterations perhaps to the lead placements that are used, or even to the settings, whether or not they make an improvement, lead to an improvement in cognition is really less clear at this point. There really isn't much research in that regard. So I think that's really, about what I can say about that.
So but I think you alluded to this as well, that cognitive dysfunction would be a reason not to pursue DBS. Is that also true?
We all saw enough cases, I think earlier on in the history of DBS, where patients had significant cognitive impairment going into the surgery and did not tolerate that as well. I think we all recognize that if you have significant cognitive impairment and you go through any medical procedure that involves anesthesia, but now we're talking about brain surgery, that you are more likely to develop confusion in the immediate aftermath and even worsening cognition longer term. Mm-hmm. So I think most DBS centers now, or most neurosurgeons, will require that a person have detailed neurocognitive testing prior to the surgical procedure. And if the patient tests normally from a cognitive standpoint, or has at most only mild cognitive changes, then it's usually appropriate to proceed with the surgery if the person's otherwise a good candidate. But if it's more than mild cognitive impairment prior to the surgery, typically that person should not be operated on.
Okay. So we're starting to wrap up our discussion. Is there anything else that we didn't have a chance to discuss that you would like to communicate to our community?
Let's see, we've talked about cognitive impairment, we've talked about psychosis a little, depression, anxiety, impulse control disorders. We talked about deep brain stimulation, non-motor fluctuations. I think we've covered a lot of the ground. There are some other symptoms that can happen that sometimes people aren't aware of that may not necessarily be clinically that significant. So for instance, what we call pseudobulbar affect, where patients can sometimes develop episodes of spontaneous crying, sometimes laughing, but more typically crying. And patients and family members may become alarmed because they think there's something wrong, or that this means significant depression, but it's just part of the brain changes that can occur that can lead to this. And we do have antidepressant medications that can be helpful for that. And I think another symptom, we didn't discuss REM behavior disorder, RBD. It's a sleep disorder, but for me, it's also falls under psychiatric disorders, but that's a big topic to cover in a short period of time. I think the other one that we haven't really talked about, and we don't have great treatments for anyways, is what we call amotivation or apathy. Right. And I think that's often a difficult differentiation for patients and their caregivers from depression. Right. Because when somebody is apathetic or amotivated, they tend to sit around more, they tend to communicate less, they tend to show less facial expression. And the natural assumption is that this person must be depressed. But apathy really is a distinct syndrome. It often goes along with cognitive impairment in Parkinson's disease, and it doesn't necessarily respond to probably doesn't respond to antidepressant treatment.
Any sort of lifestyle tips you could give someone that is experiencing apathy?
I've found that the families that seem to do best with that are the ones that can understand the points that I just made and not expect that patients are necessarily going to be able, or depressed, number one, or going to be able to self-motivate themselves. So I think that people that are able to kind of build a structure around the patient, just to build a routine that will get the person going up and out of the chair or the couch and stay engaged. Once that happens, then sometimes the patient, or often, is able to sustain that and sustain it through the course of a day even. So I think, to me, that seems like the most logical way to try to approach that problem. And sometimes we do use medications, even though with little evidence. There's some evidence that the dopamine agonists may help with amotivation. There's some evidence that cholinesterase inhibitors, the cognitive medication, may help. And finally, we sometimes use stimulants. Medications that are used for attention deficit disorder can also be used for apathy, and I have used that in clinical practice some.
What strikes me is, like with most things with Parkinson's disease, it's really a team approach. It's, attacking the problem from all angles, really, in order to get the best quality of life for patients. Go ahead.
Yeah, I was just going to say, I feel very lucky at both University of Pennsylvania and at the Philadelphia Veterans Affairs, the two Parkinson centers I work at, to work with highly trained and excellent movement disorders neurologists, and also other professionals, social workers, nurses, neuropsychologists, speech therapists, physical therapists, occupational therapists. So I feel like I can focus on my kind of piece of the puzzle and try to develop my expertise in that area, but know that I can rely on these other professionals to take care of their end of the illness.
Right, and I think that's something that we as patients have to learn, is building our own Parkinson's team of people looking after our best interests. So thank you so much, Dr. Weintraub, for your insight and expert advice. It was certainly greatly appreciated. And thank you, everyone, for joining us today. I hope that you found your time useful and helpful and educational. I know I did. We will be sending you all a link for recording of this webinar in the next few days that you can share with others. And remember, it's only natural to have some concerns about the future when you're facing a chronic progressive illness like Parkinson's disease. But it's also important not to get mired in the fear of that future, because to do so only takes away of your experience of the beauty and experiences of the present. So focus on today, on optimizing your quality of life, on educating yourself and empowering yourself, and celebrate your daily victories. Thank you, everyone.